Good evening, dear colleagues. My name is Dr. Abdul Kader Baalbaki from Beirut, Lebanon. I earned my bachelor degree in oral and dental surgery 2020. Today I am last year resident in prosthodontics and aesthetic dentistry. Also, I earned my degree in advanced general dentistry program 2021 and my diploma in oral implantology 2022. First of all, I want to say thanks to Professor Mazen Domani for his invitation to the Dentistry Online conference in its 10th edition. It is such a great honor and pleasure for me to present at this channel. Truly this channel is very beneficial, and personally I have benefited a lot, especially in my undergraduate studies and even in my post-graduate studies. So thanks, Professor Mazen. Today my lecture with my colleague Dr. Melhem Kaassamani, which is also a resident in oral surgery and implantology. We will talk about the PRF technique. This technique that is considered a controversial issue in dentistry, where we can apply it nowadays, and its advantages are so many. So in our lecture we will confer in details about its role in the healing of extraction socket and its role as a growth factor in different clinical applications. In addition to that, we will talk about its advantages, about its preparation in details, and how can we apply it in different situations in dentistry. Finally, me and my colleague Dr. Melhem Kaassamani will share our clinical cases, our 5 clinical cases, where we use PRF in immediate implant placement, or in failed implant, or where we need internal sinus augmentation, and we will show you how PRF is really a game changer. So tooth extraction, let's start. Let's suppose that a patient came to your clinic in pain. Of course, you will do your clinical and radiographic examination in order to confirm accurately your diagnosis. So you have done your examination, and the X-ray revealed either a fracture or a post-fracture, as we see here, a post-fracture in the root of the tooth, or endodontic complication which cannot be resolved. So of course our decision will be tooth extraction, of course. So we will extract the tooth. Of course, the patient will not, he does not want to extract tooth and that's it. No, he wants either a fixed portion denture or a dental implant that will restore function and aesthetics. So the operator or the clinician should tell the patient that the tooth extraction, when he extracts the tooth, it will take time to heal. So eventually it will take time to do his final procedures. So he should know that he wants to extract his tooth and wait for a limited time in order for that soft tissue to heal or the bone to grow and regenerate, especially in dental implant cases where we need bone. Of course, I'm not talking about immediate placement. I'm talking about delayed placement where we need a good quantity of bone. So tooth extraction healing process will take time. Healing of extraction socket is a complicated process where it involves 4 overlapping stages that are modulated by various growth factors and cytokines. A complete sealing of the socket with matured mineralized trabecular bone and marrow is achieved around the 12th week on average. So as we see, we have 4 stages. The first stage where we extract the tooth. Within a week we will have a granulation tissue formation. Second phase is epithelialization, where the granulation tissue is gradually replaced by the epithelial cells. The third phase is wound contraction, and finally remodeling. So eventually it's a time-consuming process that it will take time. The patient procedures will be delayed. In addition to that, there will be soft tissue changes and hard tissue changes, where the gingiva will take about 2 to 3 months to completely heal. In addition to that, with respect to the hard tissue changes, a lot of studies reported, especially Carlson, that will be bone loss. Bone loss means more delay, which means we need to put bone graft, then wait to put our dental implant. So what is the solution? How to accelerate the wound healing in order the patient not to wait a lot? This study by Dr. Tamama in 2015, by the way, this study is a very very good study that that I want, if you can read it. It's a good article. I really recommend it. It talks about the acceleration of wound healing by multiple growth factors and cytokines. So Dr. Tamama had suggested to apply multiple growth factors in the extraction in the wound or the extraction socket in order to accelerate the wound healing. So we should know also that the healing of hard and soft tissue is mediated by a wide range of intra and extracellular events that are regulated by signaling proteins. Although the knowledge about these molecules remains incomplete, platelets have been found to play a crucial role not only in hemostasis but also in the wound healing process. So we should know about the platelets. What are platelets? Platelets are anucleate cytoplasmic without nucleus fragments containing alpha granules that are spherical or oval structures with diameters ranging from 200 to 500 nanometer. They form an intracellular storage pool of proteins vital to wound healing, including platelet-derived growth factor, transforming growth factor, and insulin-like growth factors. So numerous techniques of autologous platelet concentrates have been developed and applied in oral and maxillofacial surgery. The first generation incorporates the PRF or the PRGF, which corresponds to platelet-rich in growth factors, and the second generation platelet concentrate involves the PRF or platelet-rich fibrin. So PRP or PRGF, as recommended by Dr. Tamama, it's a traditional growth factors, platelet-rich fibrin, which are more modern growth factors, are more widely used nowadays. So let's give an overview about the PRP and the PRGF preparation. First of all, we should know that the preparation for both is the same. Clinically, platelet-rich rich in growth factors can be differentiated from PRP in that it needs a smaller volume of blood and prepared by a single spun only. While PRP or platelet-rich plasma, it is defined as a sample of autologous blood with concentrations of platelets above the baseline values. In dentistry, PRP was first introduced by Marx in 1998 in combination with autologous bone grafts for the reconstruction of mandibular defects. So let us now talk about its preparation. Its preparation is considered time consuming since it requires 2 times to centrifuge, which need more time and possibility of contamination, because we need to take 2 times blood from the patient. So first of all, 20 to 50 millimeter of venous blood is withdrawn from the patient before the surgery into the tubes containing anticoagulant such as citrate dextrose A, as we see here. This blood is first centrifuged for 5 minutes at 1100 rpm, which results in the separation of whole blood into 2 layers, as we see in this tube. The upper yellow plasma layer containing platelets, leukocytes, and clotting factors, and the lower red-colored layer containing erythrocytes or RBC. The yellow plasma layer is separated and the lower erythrocyte layer is discarded. This yellow plasma layer is again centrifuged at 2500 rpm for 10 minutes. After that, this will result in the separation of plasma into 2 layers, upper platelet poor plasma and lower PRP. The upper platelet poor plasma is discarded and the lower PRP is preserved for the use during bone augmentation procedure. Once the PRP is ready for use, it should be clotted by mixing it with the activator, either thrombin or 3-ACL2, just before using it. With respect to its application in guided bone regeneration, this PRP gel cannot be used as a barrier membrane because it does not prevent the fibroblast from invading a bone graft site over an extended period of time in comparison of what the barrier membrane does. However, it may be applied over the barrier membrane. So what is PRF? PRF, many dentists ask, is it a friend or foe? Of course, any technique has its advantages and disadvantages, but personally I have been using the PRF and its advantages are ways more than its disadvantages. So platelet-rich fibrin or PRF was developed in France by Dr. Joseph Chukroun in 2001. It is considered as a second generation platelet concentrate, which is widely used to accelerate hard and soft tissue healing process. It is strictly 100% autologous fibrin matrix containing a large quantity of platelet and leukocyte cytokines. Unlike other platelet concentrates such as the PRP and the PRGF, this technique does not require any anticoagulant or bovine thrombin. The PRF is prepared by centrifuging the natural blood without additive. The PRF is accumulated of platelets and release cytokines in a fibrin clot. It is considered a safe procedure since we are taking blood from the same patient. So less contamination. As corresponding to its mechanism of action, as we say before, it is considered a true game changer. PRF has the potential to promote bone regeneration through the activation of various signaling pathways and the regulation of gene expression, making it a promising candidate for alveolar bone regeneration. PRF has been extensively researched due to its abundance of growth factors and cytokines, as well as its ability to act as a structural scaffold promoting the healing and the regeneration of damaged tissues. So why PRF? PRF is considered as a biofuel for tissue regeneration as recommended by the literature and studies. So PRF offers various advantages over the better known PRP and PRGF, and that include ease of preparation, ease of application, minimal expense, and lack of biochemical modification, as no bovine thrombin or anticoagulant is required to be mixed. So how PRF is better? In comparison to PRP, the majority of cells in PRP are in the low compartment of the tube, while the majority of cells in the PRF are in the high compartment of the tube. This reveals that And PRP will have more faster centrifugal, PRF will have slower centrifugal and more release of cross factors, unlike the PRP where will have faster release of cross factors. PRP include additive, making it uncomfortable, and there's chance of contamination, as it requires 2 centrifuge and it's more time consuming. While the PRF, it's 100 natural percent and additive free, taking it from the on patient blood. So PRF as a smart blood concentrate, APRF by Dr. Chokran is considered a game changer, as we say before. We should note that APRF differs from the PRF is that APRF require at the centrifuge machine 1500 RPM for 15 minutes. It differs from the standard PRF, which is 2700 for 12 minutes. By decreasing the centrifugal RPM and increasing the time from 12 to 15, this will give enhanced neutrophil granulocytes in the distal part, as we see, of the clot. With respect to the IPRF, it's recommended by Dr. Chokran to put it at the centrifuge machine for 700 RPM for 3 to 4 minutes. The injectable PRF is used for hair treatment loss in addition to facial treatments. But in dentistry, this liquid PRF mixed with we can mix it with allograft in order to form sticky bone, which will use for augmentation procedures around the dental implants. The rationale behind the invention of APRF and why it's so important, we should know that the monocytes release higher concentration of growth factors. As I say before, by decreasing the centrifugal RPM and increasing time, this will give enhanced neutrophil granulocytes in the distal part corresponding to the yellow color of the clot. After that, neutrophil granulocytes will increase the differentiation of monocytes. The PRF clots formed with APRF centrifugation protocol showed a loose structure, as we see here, with more interfibrous space and more cells in distal part of the fibrin clot. The distribution of cells is even in APRF cells. And now I will leave you with my colleague Dr. Melhem Kaassamani that will talk in details about the clinical applications of PRF.
Good afternoon, my name is Dr. Melhem Kaassamani. I'm owner of Kaassamani Dental Clinic and resident in oral surgery. We are going to talk about clinical applications of PRF. PRF has been used in different clinical situations like periodontal bone defects, localized osteitis, extraction sites, sinus lifting procedures, internal or external, failed implants, or when we have bone resorption around implants, potential scaffold and pulp revascularization procedures, and bone regeneration around immediate implants, which improves also in the stability of the implant. This is an article which was performed in 2020, which talks about the influence of platelet-rich fibrin on wound healing and bone regeneration around the tooth extraction. We can see two diagrams, diagram A and diagram B. In diagram A, we made extraction of the tooth, and then we place inside the socket the PRF. We can see the difference in bone and tissue healing in the extraction site between diagram A and diagram B. PRF is significantly better in promoting soft tissue healing and also hastens bone formation in extraction socket. PRF may be also recommended as a valuable material for encouraging soft tissue healing and bone regeneration. This is another article which talks about the sinus lift procedures which PRF is used in. As we said, PRF can be used in both external and internal sinus lift with or without bone graft. The application of PRF can be either with or without bone graft, reduce in time for new bone formation and consequently the time necessary for implant rehabilitation. Thus, it is suggested that the healing period can be shortened when PRF is used in the maxillary sinus lift elevation surgery. Another article which talks about clinical application of PRF to enhance dental implant stability. Whenever we want to put implant in place, we can use a PRF with it to promote the osseointegration directly over the implant and better bone formation around the implant and improves in the stability of the implant. PRF may be able to improve the stability of implants after implant surgery. Compared with other biomaterials, the application of PRF may accelerate the bone healing process. Another article which talks about the implant placement, which talks about the sticky bone placement in the extraction site, which was done in 2018. Immediate implant placement followed by sticky bone and PRF membrane placement to achieve osseous regeneration. The use of sticky bone and PRF membrane during placing an immediate implant aids in its stable through hard tissue regeneration and formation of bone around dental implants. First, we can place the implant, then we can place the sticky bone around it, and then we can place above it the membrane. Which is better now, PRF or both? I can say that both mixing PRF and bone graft is the ideal choice. Another article was made in 2019 which is about the PRF with mixed particulated autogenous bone grafts in the treatment of bone defects and experimental and histomorphical study. How to prepare PRF? First, we perform a blood withdrawal from the patient inside the tubes. Then we put them in the centrifuge, and then we have the blood will be separated. Where we have the PPP and PRP and lowest with the highest density, which is the RBC, and we have the PRF. What we need for our PRF technique? We need our kit, of course, the centrifuge, the box which contains the plate to compress the PRF and to get the membrane, the stainless steel cup for sticky bone formation, and the bone condenser and scissor and tweezer. First, as we said, we perform blood withdrawal from the patient. 10 to 20 millimeter of venous blood is withdrawn from the patient and immediately put into the test tubes. Then the blood tube is put inside the centrifuge. We spin the tube at 1300 RPM for 8 minutes. When the tubes are removed from the centrifuge, the blood is separated into 3 layers. The top layer contains the platelet poor plasma, which is the PPP, as we said, and the middle layer contains the fibrin clot PRF, and the lowest layer contains the RBC. Unlike PRP, the PRF results from a natural and progressive polymerization which occurs during centrifusion. This fibrin clot PRF is grabbed and gently removed from the tube using tissue forceps. As we can see on the slide, the fibrin clots are separated from the attached RBC using scissor and stored in a sterile metal drawer. Application first we are going to perform a sticky bone formation. We mix the APRF with bone, where the fibrin clot can be fragmented into several small pieces and mixed with the bone graft to enhance the bone regeneration potential of the bone graft. After mixing the APRF with the bone graft, we wait for several minutes, 1 to 2 minutes, and we can have the sticky bone, and we can place it inside defect or beside the implant. Membrane formation. The PRF clot is placed on the grid in the PRF box and covered with the compressor lid, which squeezes out the fluid from the clot. The membranes formed using this method had constant thickness, which remain hydrated for several hours and have recovered to the serum exudate expressed from the fibrin clot. Now the osteotomy irrigation. After extraction, or whenever we want to put the implant after we drill inside the bone, we can perform osteotomy irrigation. We irrigate the socket with PRF liquid. The clot can be squeezed between two gouges pieces to obtain an inexpensive autologous fibrin membrane. The serum oxidate expressed from the clot is rich in proteins such as fibronectin and fibronectin. This oxidate may be used to hydrate graft materials, rinse the surgical site, and store the autologous graft. Now we want to talk about our PRF clinical cases. I will leave you with Dr. Abdul Baalbaki to talk about internal sinus lift using APRF technique.
So after diving deep into our PRF technique, so it's important to share our clinical cases. These clinical cases are done by Dr. Melhem and Dr. Abdul. So case number 1, I will talk about the PRF and internal sinus lift procedure at the same time with implant placement. So as you know, in the posterior maxillary area, insufficient vertical height of the alveolar bone due to the presence of the maxillary sinus, post-extraction bone resorption, and poor quality and the quantity of alveolar bone may limit implant placement. In such cases, several sinus augmentation procedures for implant placement have been introduced since 1980. The techniques create space between the maxillary alveolar process and the elevated Schneideren membrane, which is filled with various graft material to maintain adequate space for new bone formation. Many graft materials have been applied to these techniques, such as autogenous bone, allograft, xenograft, alloplastic bone, or combination thereof. Although autogenous bone is considered to be the gold standard, it creates another wound at the donor side. Thus, autogenous bone is not widely used. So, in this case, we have used the PRF. So initially, this is X-ray. As we see the sinus invading, as we measured of the CBCT, it is 6 millimeters. So we decided to go for internal sinus lift, of course. So this patient, a 60-year-old patient, came to our clinic at Kaassamani Dental Clinic in Lebanon, reporting that he cannot eat, so he want dental implant in order to restore function, in order to eat properly. So after adequate examination, his medical examination was not applicable, free of any diseases. So we start our. He reported that he had extracted these teeth 1 year ago. So of course there's adequate bone fill. In addition to that, the CBCT confirmed that, but the maxillary sinus is invading. So of course we cannot place our implants, or we will end that our implants will be in the sinus, and it will lead to complication. So as we see here, first of all, we perform our surgery in a very clean aseptic site. We open our flap, full thickness mucoperiosteal flap, completely in order to see well. After that, we start with our osteotome preparation. We start with our round burr, then our paradrill. Then we put our parallel pins in order to see our parallelism. After that, we complete with our sequential drilling. After finishing our drilling completely, we take blood from the patient, as you see. We collect the blood, we put it in the centrifuge machine. After putting it for 8 minutes, it separates into red blood cells and into 3 layers. After that, we extract the fibrin by the artery forceps, and we discard the RBC from it, as we see. And we put the dental implants in order and we compress the PRF in order the implants to be supplied from the fibrin. As we see here, we put the PRF inside the hole, and finally these are our implants. This case we had done it nearly 1 month ago, and yes, PRF, and I was satisfied enough to say yes, this surgery had been succeeded. Of course, we cannot now confirm. We should do CBCT every 3 months in order to make sure of our implants. Case number 2, PRF and immediate implant placement. In these cases where we extract the teeth and we place immediately, we have done our preparation, as we say before. We have taken blood from the patient, we put it in the centrifuge machine, we have the PRF is ready, we put the PRF inside our preparation, and then we apply our dental implant. Yes, it's a very beneficial technique where we achieve high primary stability. And now I will leave you in case number 3 and 4 and 5 with Dr. Melhem Kaassamani.
I will talk about case number 3, which is PRF and filling of cystic cavity. First of all, the patient was reported to our clinic suffering from pain in the lower left mandible. After clinical examination and diagnosis and radiographic examination, we can see that the patient have a large cystic cavity. We performed CBCT and biopsy to confirm the origin of this cyst, what it is, and the cyst was a keratocyst. After that, we appoint an appointment for the patient for the surgery. As we can see, we performed a full mucoperiosteal flap. We can see that the cyst is large and the sinus tract of the cyst, we can see it. Then we made a hole inside the cyst and start cleaning it with curettage and irrigation. We can see the amount of large quantity of yellowish cystic fluid coming out of the cyst. After fully cleaning the cyst with curettage and laser, now we want to perform our treatment. Our treatment was to fill this cystic cavity after cleaning with sticky bone and above it a membrane, and then suture it in place. We perform our sticky bone by taking PRF liquid and mixing it with bone graft. After 1 to 2 minutes we have a sticky bone, as we can see the picture on the right side. And to perform the membrane, or to make the membrane, we take the PRF and the APRF and we place it between two plates. We compress it, the liquid will come outside of the PRF, leaving the membrane in place. Then we put the sticky bone inside the cavity and condense it in the cystic cavity and place above it the membrane, which is the whitish one in the middle picture, and then we suture the flap inside. 1 year follow up, we can see that the cyst is clean and resolved, and there is bone formation ready for the another treatment, implants or bridge or removable denture. Case number 4 is about PRF and socket preservation. After extraction of these hopeless first molar and second molar, we want to put implant in place, but first we want to perform socket preservation. First we extract the teeth, and then we perform the sticky bone. We put the sticky bone in place and the PRF, the membrane, above the sticky bone, as we can see in this slide. Case 5, PRF and failed implant. The patient was suffering from twice failing implants, so the patient was reported to us. We removed the failed implant and then we performed curettage. We can see the damage caused by the failing implant where there is no bone sufficient. We mix the PRF with bone graft, and then we wait for 1 to 2 minutes to have the sticky bone, and then we put them in the socket and suture, and we will wait for 3 months then to put the implant in place. Take home message: PRF is a true game changer. I honestly use it in every single implant case I do, or cyst, or even in extraction of third molars. I usually put PRF in the extraction site, which enhances healing and better comfort for the patient. Thank you all for your kind attention. Dr. Kaassamani and Dr. Abdul Baalbaki. If you want anything, you can mail us at our email melhem